We will start with the contact person for the CDC, Madame Koskimska, for the first question, if you have any.
Bardzo dziękuję, Panie Przewodniczący.
Thank you very much, Chairman. And thank you, Dr. Ammon. Thank you very much for your comments and your participation in this exchange of views. In our first meeting after the summer break, I would like to thank you very much for the contact that we had with you during the summer break and the ongoing flow of information, particularly the answer that you gave to the question I raised about the risk assessment published by the ECDC in August this year. So I have a question now about the European Ombudsman. Last week, the ECDC received a letter from the Ombudsman with a list of questions with a request for answers. Please, could you give us any more some more detailed information about the causes of that letter? The EU administration needs to act in a transparent way during a time of crisis. Could you tell us a bit more about the questions that were raised to the ECDC? I also have a question. It seems evident that the real number of cases may be 2 to 4 times higher than the statistics show. In this week, in the Journal du Dimanche, the newspaper, a French expert on infectious diseases was quoted. He is in charge of one Parisian hospital, and he said that every day between 5,000 cases are detected, but the real number is probably between 10 to 20,000. So in this context, could the ECDC talk about the way it carries out computer and mathematical modeling and how you plan to monitor the trajectory of the pandemic and how a second wave might look and what we might expect in the year to come? Different statistical models could be very helpful in planning the next steps and allow us to reduce economic losses. When you model the second wave of the pandemic, would it not be useful to include this factor in the models? Do your mathematical models confirm the fact or the hypothesis that there may indeed be 2 to 4 more times the number of real cases than there are in the statistics that we have? Thank you.
Thank you. So we will take a few questions and then you will have a first round of answer because we have time and there are a lot of questions. So we will move to Peter Liese from the EPP.
Yeah, thank you, Chair, and apologies. I have just been able to connect because there was a technical problem. So I missed the speech of Mrs. Ammon, so apologies when I refer to something that you have said, Mrs. Ammon. But we had the privilege to talk earlier this week, so I think I'm quite aware of your ideas. Thank you for all the efforts. You know, in general, I think it's very clear that Europe needs a more coordinated action when it comes to the analysis of the situation and the reaction to the threat. And that's why I think we need a stronger ECDC. Maybe you could outline the main points where you think we, together with the Commission, should enable you and the Council to do a better job to help to fight the pandemic and to make the ECDC stronger. But I have also 2 concrete questions. When I look at your figures from this morning, it's quite interesting that some countries where the Hungarian government exercised a travel ban have lower numbers than those where the government didn't. For example, the Czech Republic, according to your figures, has 41 cases per 100,000 in the last 14 days, while a country like Denmark has 20,000, Lithuania 20, Estonia 13, Lithuania 16. So can you confirm these figures? The political analysis is of course a different thing, but I think the travel ban in Hungary has by no means been based on science and on facts. The second question, there are different recommendations in the member states how long people should stay in quarantine. For example, Austria recommends 10 days and many other countries 14 days. What is the effect of this different recommendation? Is it a huge problem? According to my understanding, the spread of the virus is very dangerous 5 days after the infection, and it goes down quite significantly. So if we really keep it under control, and if we have a guarantee that people keep the quarantine, wouldn't 10 days be a good compromise? Thank you.
Thank you. For SND, Jutta Gutteland.
Thank you. Can you hear me?
Yes, it's okay.
Good. Thank you, Director Ammon. I'm very happy to listen to you again, and I'm also admire your work, and it must have been tremendous work for you, and it continues, and you should have all credit for constantly being updated and helping us, taking us through this very difficult time. I would like to first say that I was happy to hear how you mentioned the situation for the children. I really think it's important that with all serious measures we can take to make sure that we don't spread the virus, still make sure that the kids will have a grow up that will make sure that they have their education, and also socially that they will not have big problems during this time. I believe this is also for health very important. Thank you for mentioning that. And then I have two questions. Recently, there have been growing evidence of patients attracting the COVID virus a second time due to mutation of the virus. Of course, you know that. And maybe I missed if you already mentioned it somewhere. But what's your assessment of the risk of becoming infected a second time, and how does this implicate the measures that the member states should take? Because if the risk is very huge, then of course people should not relax if they had it. But I would really like to hear from you how you assess this. Then my second question is if there has been any progress during the summer in the efforts of harmonize how the member states collect, report data on COVID patients and their fatalities. The discrepancies on how this data, discrepancy about how this data is collected are used differently in member states, and it makes it really harder to get a clear picture of how the situation looks in Europe as a whole. And I really believe this is serious, and we also use that data very much against member states and get measures to some member states and not to others. So it's really important that they are harmonized and that they function sufficiently. Thank you.
Thank you. For Renew, Véronique Trier-Lenoir. Vas-y.
Merci beaucoup.
Thank you very much. I didn't hear you giving me the floor. Dear Dr. Ammon, on behalf of the Renew Group, I'd like to thank you for being here today and for your presentation. The We've seen internal borders across Europe all summer. We've seen unilateral decisions, disorganized rules based on different mapping exercises. The results of tests are being challenged in one country and another. With the closure of internal borders, tourists are experiencing a new form of sanitary or hygiene nationalism. Many MEPs have certainly seen this too, and all of this will have not just healthcare impacts, but also an impact on the political, cultural and scientific life in Europe. The free movement within Schengen is a right that we are particularly attached to, and it is being challenged here. Now, of course, the ECDC is not responsible for these this national selfishness, but the cause is a lack of confidence and trust between member states and insufficient cooperation in healthcare matters. Clearly, there are differences in the intensity of the virus's spread in different countries. That must be taken into account. What we need is to show citizens comparable scenarios for comparable epidemiological situations when they go from one European country to another. Now, when it comes to how data is collected, what criteria would you recommend to the member states? What is a case of COVID? Is it someone who has symptoms? Is it someone who has a positive test result? Is it someone who has come into contact with somebody who has tested positive but does not show symptoms? What is a COVID death? Is it someone who has died following a positive test? Is it someone who has died from COVID or another cause? Or is it a clinical suspicion to explain the death of a vulnerable person? So what numbers do you have from the different countries with regard to those tested and those testing positive? You talked about the importance of that ratio. How many countries are actually giving you this raw data, and how regularly do they provide it? Now, as regards the risk assessment criteria, what criteria do you use to establish the different mapping of the virus's spread? What conditions would you give to member states to establish zones in their different regions? Could we have a single picture on a weekly basis, and what ties are there here with the WHO who are doing similar work? I'd like to thank you very much for all of your work and for all of the information that you can provide us, because it's really fundamental.
We move to the Greens and Jutta Paulus.
Oops, does this work? Hopefully it does. Thanks, Dr. Ammon, for being with us and for answering our questions, and first of all for giving this very important overview. I have a few questions to that matter. I would like to start with the EU summit, which had taken place in July, where the EU leaders unfortunately cut down the program EU for Health, which was actually intended to help us react better in future pandemics, as we have seen the shortcomings at the beginning of the year. I would like to know, what do you think of how can EU for Health actually fulfill its mission when being cut down so much? Secondly, in my opinion, the huge heterogeneity in the measures and quarantine days and who is tested and what's allowed in schools, in public transport, should people wear masks, yes or no, are shops going to open, for how long, and all that. This does not help at all, because I believe that people are just getting confused. They don't know what to believe, saying, well, on this side of the border, I have to behave like this and that, but 10 meters to the left or to the west or to the east or wherever, there is a totally different regime. So how will you try to convince member states to work together better and coordinate better? And one last question, what does ECDC think about monitoring the pandemic by measuring the virus concentrations in sewage, which has been examined in quite a few studies, giving pretty good results actually to have at least a notion of the transmission rate when the test strategies of the member states are so different. Do you think that this should be a route to be explored further, and would it be possible that ECDC themselves could commission these measurements? Thank you very much.
Thank you. For the GUE, Madame Konieczna.
Thank you. Dear Mr. Ammon, thank you very much for another comprehensive presentation, and thank you very much for your work and all your agency and the people who work with you, because I think that it's very hard work, and now could see anybody how big it is. However, one thing strikes me on the current situation and practice of the member states. Unfortunately, it's not unique, but it has become the standard. And this is the mutual non-recognition of tests performed in one state by the authorities of another state. We all saw that with our own eyes after our return from holiday, especially back to Belgium, because countries like Belgium or Hungary will not recognize a test taken elsewhere, even if they are only 2 days old, as the proof of non-infectivity, and at the same time required a test performed by their laboratories. Should I understand it like that the doctors and laboratories in other member states do not operate under the same standards, and that their results, they are therefore inferior? Or where does this mistrust come from, which greatly complicated the lives of people who are forced of travel? Why have not been the proposal to unify this practice? How is it possible that the tests are not mutually recognized, even if they are taken 1 meter beyond the border of the particular state? Do you have information that the Commission or perhaps your agency is planning any measures in this area? I think it's not trouble only for MEPs, but it's trouble for everybody across the Europe, because if you need to travel, you know, and you need to know that the standards will be only one. And if you haven't some plan, please prepare, because especially in autumn, I think it will be bigger and bigger problem for everybody. Thank you very much.
Thank you. So, Madame Ammon, I suggest you start with the first round of answers, and then I will start again the catch the eye for the remaining questions. Floor is yours for 10 minutes.
Oh, wow. Thank you. I will start. That's not fair, letting me know more and then reducing. Anyway, I try to be brief. Regarding the Ombudsman, that is a own initiative of the Ombudsman, and I have actually no further indication than what they have said in their letter. They want to ensure the transparency of the EU administrations, and have specifically asked us how, especially in the early days, we have obtained our data. They have asked for the service that we have carried out, and we have now submitted all the data, and we have to await their analysis. In general, I believe we have adhered to all the data protection and transparency rules that there are. So in that sense, I don't feel we have obtained any data in a obscure manner. The real number of cases is for every infectious disease for every infectious disease, the real number of cases is higher than in the official statistics. That is something that is not new and is not exclusive to COVID. Now, these figures that Ms. Kopczynska has mentioned are something that people have often quoted, and when these serological surveys were done, it was hoped that by this assumption that a lot more people have been infected, a lot in these serological studies, a lot more people would turn out positive, meaning they had the virus. The evidence that we have so far is not into this. We have still seen, largely below 20%, in special settings a bit more, percent of the population shows signs of having been exposed to the virus. So as to the extent that real infections have taken place, I can only say it's most likely more than we have captured, but how much more is very difficult to say at this stage. The modeling is something that can, of course, project figures. The difficulty that we had throughout the summer and also now is that the measures that have an influence on these the future development are taken really very dynamically, and these measures have always an influence. So any models that go really long term are risking to be just outdated by the fact that measures have been taken and the assumptions that go into these models are not correct anymore. So we have been very cautious to provide long-term modeling. We do at the maximum 30-day projections that already may not be valid because in the meantime measures have been taken. But that is sort of what we are looking at. In terms of the meeting of the health ministers in July, the ideas proposed there are really congruent also with what our observations are, what has to be strengthened. The innovative digital solutions that is from our point of view in particularly necessary for surveillance, where we see that there are delays because the current surveillance systems require human input by experts that are now occupied with finding cases, finding contacts, and so forth, and monitoring contacts. So there, increased digitalization would certainly help. We also agree that the preparedness plans have to be A, strengthened, and B, also be made more interoperable, meaning more linked to each other at the EU level, but then also linked with the member state levels. And I was a bit surprised, but there was the proposal to change ECDC's mandate to issue scientific recommendations. This is something that was a taboo for us since 15 years, since our inception. Countries didn't want us to recommend anything because taking measures is the prerogative and the competence of the member states. And our mandate ends at the risk assessment and providing options for response. So that would be really something different. I just want to come very briefly to the quarantine length. We are looking into this right now, and what has to be clear is that even after 14 days, which is until now the standard, around 3 to 4% of cases will develop their infections after these 14 days. So 3 to 4% of cases will not be captured by this quarantine. And of course, the more you reduce it, the more of these cases will go undetected. And that is something that we're looking into to see, at least to provide some evidence for the decision makers, what kind of risk they would be taken if the quarantine would be shortened. The second infections, there were a few reports, and they were due to different viruses of the SARS-CoV-2 virus variations. What has been shown, though, is that the people infected with these for the second time had so far all milder infections, which means that this first infection may have helped to build some protection immunity even against the variations. We don't have right now evidence that this is a very frequent phenomenon. So the majority of the viruses circulating is still the one kind, but we are observing this, of course. And regarding surveillance and the progress in harmonizing and reporting, I mean, as I said in my introduction, collecting and reporting is sort of what comes out of the testing. So for us, the harmonization should really go now into the testing, because for the data collection, we have harmonized. I mean, the surveillance protocols have been standard since February. But what goes into this, that is the question. There were a number of remarks about the decisions that member states have taken, and I really don't want to comment on this because I think there's recognition also with the authorities in the member states that this is not a good situation, and they're really discussing now to harmonize this. And second, it is the prerogative of the member states to take their measures. So I think it's not my place to comment on this. Regarding the EU Health Program, yes, of course, it was good to see that it was boosted, and now we're back to what we usually have. Actually, not to what we usually have, because it already increased to what we have now. But in general, I think then if you have less budget, you also have to adjust the ambitions, and that is what is being done now. Regarding the sewage, we actually do not have. Das kann ich nicht lesen. We do not have yet looked very much into this, but I think we can do this and have and see whether this is really an additional measure. It would not, in my view, replace any of the surveillance that we have in place. I'm not even sure it's an early warning, so that these are the kind of elements that we would have to look into. Yeah, I certainly have not answered everything, but my 10 minutes are long over.
No, it's okay. Take an additional 2 or 3 if needed.
Yeah, okay. the case definitions were asked for because I mean there is a standard case definition at EU level. We have taken pains also to harmonize this with the colleagues in WHO, and that case definition defines suspected cases where you have not so much confirmatory evidence, especially no laboratory confirmation, then probable cases where someone, for instance, is in an outbreak, where a case has been diagnosed with SARS-CoV, and then the laboratory confirmed cases. And usually what we get reported are the laboratory confirmed cases. There is also a case definition for death of COVID, and that has been made known to the countries, and that is also something that is periodically reviewed if there are new symptoms, for instance, that have to be added, and so forth. That was it.
Okay, thank you. So we're going to move to the second round. I have 12 questions. So please, 12 speakers. So please stick to one, maybe 13. Please stick to one question per slot. Otherwise, we will not make it. So we'll start with Dolores Montserrat from the EPP.
Thank you, and thank you to the Dr. Ammon. I'm going to speak in Spanish. Una cuestión. Hay un solo mapa europeo que es del Centro de Prevención, que es donde marca las zonas rojas, naranjas y amarillas, pero hay 27 respuestas diferentes que están provocando desorientación, incertidumbre e inseguridad a toda la ciudadanía europea, a todos los sectores.
Sí. So there are problems for workers, for families, and so on. And so we need European criteria in order to avoid problems in the healthcare sector, in security, and in the right for citizens to move around. We know that this is a member state competence, but we know that the reality has changed. This new reality means that we must be realistic as the European Parliament, as the EU, the ECDC. We all need to come together to provide a single response. And my second question on statistics. The Spanish Statistics Authority talks about 40-something thousand deaths, and another body says 50,000, and the government talks about 29,000. So my question is as follows. Is the data that you're using, the data coming from governments or somewhere else? Because what we need is harmonization with regard to data. Otherwise, we don't really know what we're talking about. And my third question is, has the ECDC prepared a coordinated protocol with the member states for seasonal flu so that these protocols will apply to everyone and we'll be able to deal with the flu as well as with the coronavirus? Thank you.
Okay, 3 questions. Sarah Cerdas for SND.
Thank you, Dr. Andrea Ammon, for being here and talking to us. As we speak, many EU countries are starting the school year, and as you said, the ECDC launched a Q&A file about school settings and COVID-19 transmissions. Some actions were recommended, such as increased physical distancing, improved ventilation, regular hand washing, and use of masks when feasible. However, most schools have limitations on their physical space, making it the increase of physical distancing and some very difficult, and some schools are not prepared to improve ventilation without affecting heating. So my question is, are member states having different approaches to school opening challenge, and how is the ECDC following the implementation of these recommendations? I also have another small question, which is a topic that has become very, very urgent. In the last few weeks, we have seen an increase on conspiracy theories against COVID-19 and also the preventative measures. And how is the ECDC as an institution prepared to tackle this misinformation stream, and what is the plan to work with other EU institutions and member states to mitigate the decrease of trust on the technical scientific institutions such as the ECDC and WHO? Thank you, and sorry for going over.
Thank you. Martin Ocic for Renew.
Thank you, Chairman, and thank you, Dr. Ammon. I would just like to, first of all, underscore the need to have really harmonized data in the EU. I think this is a shame, and I think it's a shame that it falls on the shoulders of our member states' governments. We need EU-wide methodology, but we need also not just EU-wide, but and not member state-wide effective reproduction numbers. I would like to know from you, how do you see it possible, and how do you see the willingness of the member states to share and publish this data in a coherent way? And how do you see the possibility to have this data looked at regions? Because honestly, comparing Germany to Malta, these are very different sizes, and it's therefore very different impact. And I dare to have one more question, I'm sorry for that, and that regards the second infections. You said that it's very low probability. I think this is something which, in the case it's so low, wouldn't be good to consider to have some sort of a unified pass or a proof, I had COVID, I'm over it, which would allow at least part of the population which managed to survive this sickness to have easier travel abroad, because not without the testing. We need every testing capacity for where we need it, so not to have a double testing. Thank you.
Thank you. For the Greens, Michel Rivasi.
De ces informations.
Madame Rivasi, est-ce que vous pourriez appuyer sur le bouton Speak, s'il vous plaît?
Voilà.
Okay, can you hear me now? Right. Well, I would like to thank the director of the ECDC for the information, but I'd like to come back to a really fundamental matter that is causing distrust among European citizens. Right at the start of the epidemic, we had a very large number of hospitalizations, lots of intensive care patients and deaths, and these varied from one country to another. Now, because of we've seen many more tests in different countries, we are seeing an increase in the number of contaminated people, but not an increase in hospitalizations, intensive care patients, and very few deaths. And so the question I have is as follows. How do you explain this? Is it that the virus has changed and mutated, and it is just as contagious but less fatal? Or are we providing better treatment? So how do we explain this difference? We might also panic and scare people, even when the number of deaths in European countries is currently very low. That's my first question. Secondly, cases of recontamination. I saw there was one case in China. Have we seen any cases in Europe where people who were infected have been reinfected several months later? If that's possible, then this raises the issue of antibodies, which do not resist over time, and that does pose a problem when we talk about the vaccines.
For the GUE, Nicolas.
Thanks very much, President. Dr. Ammon, thank you very much for your clear presentation. There's a huge level of frustration. I know there is in Ireland, and I think it is across Europe. There's a mad lack of consistency. There's confusion. A lot of Europeans are crossing borders. The rules are different everywhere, and the rules are inconsistent even within member states. Now, and I know you've made the point that health is a prerogative and a competency of the member state, and it's up to them to make their own calls on issues relating to this. But do you not think that, I mean, your body, you say that your remit ends with guidance and disease control, and that it's not your job to tell member states what to do. But, I mean, in Ireland today, it's like as if the government have lost the plot. We have 50 people can go into an arts gallery, or they can go to a wedding, or they can go to a theatre. But if the Wexford Youths are playing a football match, nobody can go. Shamrock Rovers are playing AC Milan very soon in the Europa League, and nobody will be allowed to go to the match. But they'll pile into pubs that are allowed to sell food. And, I mean, where's the logic? Do you not think that there should be that the Europeans have to play a part in bringing some consistency to what's happening across Europe? I mean, while health is a member state competency, Ireland was pressured by the Commission to cut their health service over the last 10 years. And we were pressured into privatising stuff that's been detrimental to us. And it's one of the reasons why the government are afraid of their life of COVID, because our health service is a basket case. But do you not think that it's about time that there was somebody in Europe that would actually play a guiding role and bring some consistency across Europe, given that there is a lot of travel between states? And just for an added question, we're wearing masks full-time on the streets of Brussels now. Do you think that that's medically recommended? Is it necessary? Thanks.
Thank you. For non-inscrit, Ivan Susic.
Thank you, Mr. President. First of all, I need to express my regrets because there is no Croatian translation today, so I will be speaking English. You track diseases. This COVID disease has shadowed all the other diseases. So my question is short and simple about influenza or common flu. Is there influenza pandemic this year, or it is all COVID now, or what is the difference? What are the figures? Do you track the figures on influenza? Thank you.
Thank you. For the EPP, Pernia Weiss.
Thank you. I think I do have two small questions, or at least one remark and one question. And that is related, the first one, to harmonization of data. Being a nurse and also a health professional with expertise in health science, I understand the longing for harmonized data per se. But maybe the problem is that ECDC is maybe not solid in the data that is actually explaining the necessity of harmonized comparable data. So how many lives, how many money are actually lost because data and measures are not harmonized? We actually don't have that answer. Of course, as the European Parliament, we are here to support the inner market and the coherency of EU. But as long as the competences belong to the national states, and that the national states and the local authorities do not actually understand and maybe also have valid data to support that they need to cooperate more cross-border to use the same data the same way, then they will not do. And then we can argue from here to Christmas and again. So I would really like to hear what the ECDC does to actually prove the necessity of harmonized comparable data compared to lost lives and lost money. That's the one remark/question. The other one is related to before COVID, we were struggling, and we still are, and we must remember, with the climate crisis and the need for improved results on energy efficiency. And it relates to the renovation wave upcoming, where the renovation of our physical buildings could go hand in hand with actually also improving the physical environment's ability to do health prevention and to support physical distancing, to cut down the spreading of viruses, and also actually to both do decarbonization while lowering the risk of cross-contamination between people in physical buildings. So I would like to ask the ECDC, how could you maybe improve your indispensable role in the European Union by supporting the member states with extra evidence and extra tools, extra methods on how to do more energy efficiency of the building stock, while also improving our physical environment to keep us healthy and not sick? Thank you.
Thank you. For SND, César Buena.
Gracias, presidente. Me ajustaré al tiempo.
Thank you, Chairman. I'll stick to the time. A question and a request. First of all, are we in the second wave? At what point in the second wave are we, Director? Are we in the second wave? Is that confirmed in Europe? If that's the case, then are there any plans or suspicions in your directorate that there might be a third wave? And secondly, I think we need unified criteria. We need different uniform epidemiological data. This is a federal issue politically, but federal, that means federal criteria, and that's what's missing. We've seen what Hungary has done now, so my question is about the forecast. I know it's a very complex and difficult enemy. It's very difficult. There's a great uncertainty or even impossibility to plan anything, but it would be good for this committee to know what your directorate's forecasts are, and whether anything could be done with a view to having those more uniform criteria.
Mr. Hansen.
I believe it's a very difficult situation for you. You are often criticized, but you are lacking a little bit of a mandate from the member states. So there we should definitely have something to say and change. During the last meeting you were here, I asked you the question about the unilateral decisions that some member states took. We have a lot talked about that. Then I got some reactions on my Facebook from people. Shouldn't this ECDC rather be called ACDC, because this sounds pretty much like welcome to the jungle. And there I think we are at this very moment. Mick Wallace just said it. We have a lot of confusion between the member states, but as well between politicians and for our citizens. Nobody knows exactly where they stand. Is this classification correct? In my home member state, we are doing more than 50,000 tests per week, which is I think the leader in the European Union. But still, we are rather badly classified. So my one question, and I stick to one question, Pascal: how are you going to incorporate this number of testing per 100,000 inhabitants into your calculation? Because I think this is a very important aspect to add to the calculation in order to get harmonized codes that everybody here in this room is asking for. Thank you.
Thank you very much. For SND, Nicolas González Casares.
Thank you, Chair, and thank you, Mrs. Ammon, for being once again in this committee. I will continue in Spanish. Desde el mes de marzo.
Since March, I've been talking about the problems of harmonisation and standardisation of data. The problem is in the origins. I know that the EDC has made a great effort over these months, but I think more could be done with the means available today. Now we're talking about a recovery plan and a new financial framework and resilience. I think now is the time to strengthen information systems. We have sufficient technology to standardise data from the origin, from the diagnosis, right to the end of the chain, so that we can have a rapid, immediate picture to see, visualise the expansion of the epidemic and forecast new waves for this virus or even for new diseases appearing in the future. I asked some questions at the beginning of August, and I would say that I would like to ask the question again about whether a system is being developed to fight against pandemics. Do you think you have the means necessary in terms of budget and in terms of staff? Do you have the means available to do that?
Glavac for EPP.
Ms. Glava, can you please press the speak button?
Yes. Do you hear me?
Yes. Please.
Do you hear me now?
Yes.
Please go ahead. Thank you. Thank you so much. Thank you, Chair, and thank you, Dr. Ammon, for joining us today's debate. Thank you for sharing the latest news about COVID-19. I would like to hear the word of experts on two things, which we often hear about in the media, but perhaps it would be good to properly inform our citizens. The first concerns the anti-vaccination movement. It worries me to see that more and more young people are strongly opposing vaccination and are very vocal about their opinion on social media. I think you know that. We all, of course, have the right to decide on medical treatment, but do you think the anti-vaccination campaign has become worrying and what can we do about it? Another topic, in the end of summer and the beginning of colder weather, which brings seasonal respiratory disease, as you know, it seems to me that we are all concerned about the possibility of the distinction of influenza and COVID-19. In this situation, would you recommend vaccination against seasonal flu to people who may not have been vaccinated before? Thank you so much.
Thank you. And the last question from non-inscrit, Anthony Comyn.
Merci, Président. Thanks, Ms. Ammon.
Very briefly, we've been talking a lot about the economic impact of the pandemic. Perhaps we haven't talked enough about the psychological effects. We know that the pandemic has forced us to apply protocols to break the contagion chain, but those protocols go against standard protocols for mental health. For example, for older people, mental health is based on the links that they have with other human beings, and now they're very isolated. So my question is there any data already about how the pandemic has affected mental health, not just acute mental diseases, but the less acute ones? Do we have data for the entire European Union? Can we start to quantify the way in which the pandemic has affected mental health? Thank you.
Thank you for these questions. So I give you 10 minutes, Madam Ammon, if you are able to stay 5 more minutes than expected.
Dr. Ammon, can you please press the speak button?
I thought I did. So, okay, now I hope it works now. The data that we have